Hi, this is Stacy State with Advanum Health. I want to welcome everyone to today's presentation regarding prior authorizations. A few housekeeping items before we get started today. I do have all attendees on listen-only mode. However, there is a questions area of the GoToWebinar. So throughout the presentation, if you have any questions, feel free to drop those in the questions area, and we will get to those at the end of the webinar, which should probably last between 30 to 45 minutes today so that we leave room for questions. And this is being recorded, so a recording will be sent out to all attendees after the presentation. And so without further ado, I want to go ahead and introduce our speakers for today, and then we will get started. So we have two guest speakers today. The first one is Brad Jones. He's a regional account director here at Advanum Health. And as he joined Advanum Health, he brought a wealth of knowledge from his 10 years experience in the healthcare industry. For the past few years, he's been focused on practice operations and complete revenue cycle administration with large multi-specialty groups processing multiple locations in 10+ states. Brad also has had the opportunity to work extensively on the payer side and brings in-depth knowledge of payer operations and requirements. Brad holds a BS in biology, chemistry, and Spanish from the University of Louisville, a BA in healthcare management from Southern New Hampshire University, and an MBA from the College of William and Mary. He is a certified medical practice executive from the American College of Medical Practice Executives, and also holds a clinical certification as a registered medical assistant. He is a member of MGMA, NMGMA, HFMA, AMT, and AHAM. Our second speaker today is Andrea Utterbach. She is a regional account director and is responsible for account management and the success of client relationships here at Advanum Health. She is a specialist within Advanum on clearinghouse implementation, system dictionary support, fee schedule maintenance, procedure coding, and specialty physician practice billing. She is a proven manager with excellent communication across all internal and external sources. Andrea brings 19 years of experience of both independent practice and hospital-based practice management. Her background includes working for a 75-doctor practice where she performed coding and billing functions. She is also a hands-on manager who never hesitates during scheduling, prior authorizations, and payment posting. She is certified through AHAM National Board as a Certified Revenue Integrity Professional. She is also a certified professional coder through AAPC. So without further ado, I want to thank our speakers, and I will turn it over to you, Brad.
All right, perfect. Can everyone see the screen? Can you see that, Stacy, okay?
Yes, I can.
Okay, perfect. Welcome, everybody. My name, like I said, is Brad Jones. I'm a regional account director here, and I have Andrea Utterbach.
Hello.
And so today we are going to be speaking on prior authorizations, tips, tricks, and thoughts on best practices. I know this is a big sticking point for a lot of providers, both on the hospital side and the professional practice side. And so hopefully we can navigate some of those hurdles and just speak to some of that. At the end, we have a section on questions, but also, I think it would be a good idea to be able to share some of our experiences and some tips and tricks that we have among our own private practices that we utilize, so we can use that as a forum as well. So Stacy, I'll let you go ahead. We're going to have a pre-presentation poll question, and it's just to get a good background on kind of some of your current practices. So Stacy, if you want to go ahead and get that initiated.
Okay. I'm going to go ahead. There's a set of 4 questions to help both the presenters and you all get an understanding of where kind of everyone's experience with prior authorizations today. So the first question we have, which you should see on your screen, is what type of healthcare entity do you represent? You can go ahead and start answering, and it seems like we've already got some coming in. Give that a few seconds here. Okay. Looks like we had about 68% providers, 21% single provider, and 5% hospital, 5% consultant. So a good mixture today. I'm going to launch our second question. Who currently performs your prior authorization submissions and follow-up? Clinical staff, administrative staff, outsourced, or other? Okay, I'm going to close that one. So we had 52% administrative staff, 33% clinical, and 14% other. Bear with us. We just have two more quick questions to get us started. How do you manage and track your PA request status and outcomes? EMR PM system, spreadsheet, prior auth portal, paper, or other? Still have some coming in. Okay, I'll close that poll question. So we had 52% EMR PM, 9% spreadsheet, 17% portal, and 13% paper, 9% other. And our final poll question, how would you currently assess your performance with PA approvals? Excellent, good, needs some improvement, very poor. Okay, closing that one. 22% excellent, 17% good, 48% needs some improvement, and 13% very poor. All right, and with that, I will turn it back over to Brad so he can get started with some of the best practices and talking about prior authorization.
Thank you, Stacy. So yeah, that's interesting. It looks like we have a good group of mixture of people on the call today. And it looks like we kind of, self-assess ourselves among the variety, but it looks like a good majority of our pollers looks like, they feel like they need improvement. And, when we go in to talk to practices and talk to clients, that's a big thing that we notice. It's a very hot sticking point is prior authorization. So hopefully that's what we can help alleviate some questions, concerns, and, bounce some ideas back and forth today with. So today, okay, there it goes, sorry about that. So today we are going to look at an overview and background of PAs, just kind of some of the backgrounds of what a PA is and some of the necessities and things of that. But then we're going to look at the tips, tricks, and best practices that we can look at utilizing and leveraging. And then we're going to look at kind of a brief glimpse of the future of what PAs potentially look like coming up. And then, we're going to conclude our agenda and move on to the question and answers. So I think everyone here knows this is just kind of an informational slide, but what is a PA? Basically, a PA is the process in which we as healthcare providers must obtain approval before a payer will pay for a service before it's rendered or dispensed. They're known as a multitude of things: prior authorizations, prior approvals, pre-certifications, prior notifications, prior reviews. There's just a litany of terminology that different payers use. So just be familiar with that. So perspectives on prior authorizations, and those are really multifold. So when we look at it from a provider perspective, and we have those conversations, most providers are saying it's beyond frustrating. It takes up so much time. They see it as another way for payers to avoid their contractual obligations and cause hiccups in payment or just no payment at all. And then on the reverse side of that, payers are saying, it's really a way for us to be in clinical compliance, to promote best practices among clinicians, but to also for patient and member safety to that same point. But deep down too, it's also a cost control mechanism for payers. So we don't ultimately just pay for anything and everything that's being billed on the front course. So in 2017, the American Medical Association did a survey of physicians, and that survey yielded some pretty interesting things. So a physician perspective on prior authorization, now granted this survey was all perspectives from physicians on behalf of the AMA, found that 84% of physicians were extremely just off-put by the burdens associated with prior authorizations. So you can see that number is overwhelming. Look, 84% is high, extremely high, and then 12% is just in the middle, and 4 just says, oh, it's fine. So you can see the overwhelming majority there is, there's a lot of burden associated with the prior authorization process. Consequences of that. So from the provider perspective and to the truth of, in many cases, prior authorization requirements delays patient care. We see it plenty of times that, a medication is ordered, for example, and it's not on the formulary and a PA is required and the patient's not getting the medication they need when they need it for the treatment. Or the patient's needing a surgery and, sometimes at the end of the year, we're running out of the coverage period before the deductibles and things start back over at the beginning of the year, and we have to get those approvals. And that delay in patient care can really affect, the patient care, but not only that, the financial impact of what the patient may pay. Another thing we look at is the patient abandonment of care plan. So the patients get frustrated with the process and the wait so that they just give up that treatment as an option. They say, you know what, I'm tired of waiting. Let's find a different option. And it may not always be the best option for them. And that's where the next thing comes in, the negative clinical outcomes. So the patient's not getting the treatment when they need it or the correct treatment when they need it. So that's definitely a huge concern among clinicians in regards to this administrative process. So not only that, but it's increasing provider costs. So there's uncompensated overhead to staff positions in order to meet these PA requirements. So physicians are paying staff more and more money because it consumes more and more time to take care of these, to get the care that their patients need. In 2011, Health Affairs did a study and found nearly 21 hours were spent weekly per physician-related staff on PA processes. And if that were to be repeated today, that number would only be higher. And then on the backside of things, if PAs aren't obtained properly or they're outside of a service coverage date or what have you, you get the claims denials for the services for not appropriately authorized procedures, services, what have you. So that's definitely a drain on money because you spend a lot of resources, both time and physical resources, on something that you're probably not going to get paid for. So if we look at that same study from 2017 from the American Medical Association Physician Survey, you can see the consequences of PA requirements. So care delays associated with PAs. So you're looking at 15% said always there's a care delay, 39% said often, and 38% sometimes. So that really shows you 92% made up that majority of sometimes to always requiring or costing a delay to the patient's care. The next one shows the abandoned treatment, as in the perception of the providers. So they feel like 2% of patients always abandon treatment plans for best practices. 19% often do, and 57% sometimes do abandon their own care because of the administrative burdens. And then the last one there is the impact of PA on clinical outcomes. And there's a significant negative impact in providers' perceptions, 61%. 92% of people report that PAs can have a negative impact on the clinical outcomes of patients. And I'm sure you as providers and working in provider's office have seen that. Having a conversation with somebody, you can always find that one patient or that one story that we feel like we failed a patient because of the administrative requirements of a prior authorization. So that leaves us to looking at kind of where PAs are today and the prevalence of PAs. So they're definitely currently on the rise. Payers are enacting PA requirements to control costs of treatments. So when new treatment options are developed, they usually come with a high price tag. And so in response to that, payers put in PA requirements so that there's not overutilization of those services. So of course, with those new treatment options, the prevalence of PA requirements grow. I recently read, and this is where this comes from, the Centers for Medicare and Medicaid Services, CMS, implemented limited PA restrictions and requirements for items such as power mobility devices. And in that study as well, or in that article, it indicated that PA requirements will continue to likely broaden in coming years and apply to other service types. As we know now, Medicare doesn't require a lot of PA requirements for services, but from some of the things that we're reading and seeing in the industry, there's some fear there that it will continue eventually to expand. So from that same 2017 AMA survey of physicians, the question was, how has the burden associated with PA changed over the last 5 years? And you can see that the response is that it has significantly increased. 86% of physicians report PA burdens have increased over the past 5 years. So with that being said, that's kind of our background portion. So we're going to move on to kind of the tips and tricks and best practices that we have. By no means is this the end-all, be-all list. We all have our own operational preferences and how we operate. These are just some tips and tricks that we like to recommend to clients in order to get a good base standard for successful approval rates for PAs. So we kind of broke these down into some categories. And those are know what's required, streamlining processes, leveraging your resources, playing it smart, review and analytics, and communication and education. The first one that we're going to look at is knowing what's required. So I would hope at this point anyone on this call would take this one to heart, but always check authorization requirements before providing services, especially for procedural and surgical type services. You can utilize electronic eligibility through your PM or your PM system. You can use the payer website. You can call the payers directly. Use the payers' provider manuals. Those are usually good resources that are updated every year. Always check, especially if it's a more expensive type service, to see if there's requirements for PA processes before submitting or scheduling your services. The second thing is to review and utilize payer coverage determination guidelines, NCDs and LCDs, and medical policy guidelines to proactively submit necessary information on the first attempt. So CMS is a big one that comes out with NCDs and LCDs with, medical necessity kind of guidelines and what they cover and how often they cover it. But commercial payers also develop these same kinds of things that they call medical policy guidelines. So on this next slide, for example, we're going to pull up a Blue Cross Blue Shield Tennessee commercial policy, and this one's in regards to Botox. So this is actually for the drug itself. And so you can see the types of things that they list. It gives a good description of the service or product and what their policy is and what treatment types they cover. So for example, I have a really strong background in pain management, and our doctors often performed Botox injections for the use of chronic migraines. So one of the things that I would instruct my staff more commonly to do is to pull those policies and go and find what are the requirements for the prevention of migraine headaches with Botox. So then they would know, did we meet these criteria and were those medically documented so that we are able to submit a clean submission on the first time that they will consider medically necessary and pass it. So just some really good information out there. Most payers, your larger payers, will have these types of things. A lot of payers do mimic the same guidelines as CMS, but they will also sometimes have additional policies. And some payers use different guidelines. So, for example, they might use Interqual guidelines or Milliman guidelines for medical necessity. So if you have resources to those to reference, it's good to reference those and educate your providers within the clinic. These are the kinds of things that we need to be looking at preemptively before we submit for these types of services. Okay, this next thing on our list here is to streamline your processes. So the big thing that we like to recommend is focusing your efforts. So if you are a decent-sized practice or you accept multiple payers, we know that it's not possible to address every single one of those payers' requirements. So don't worry about all of your payers on the front side. Focus your immediate efforts on your top 10 to 15 payers. What we like to recommend is building informational summaries on these payers that are easily accessible to all your staff that would need that type of information. These informational summaries include things such as specific requirements of the payer, when is the best time to contact the payer to avoid long wait times, what's the payer's preferred means of contacts in regards to prior auth, is that web portal, is that fax submission, is that telephone submissions, etc. The next big thing is to track your results. If you don't have a web portal in place or you don't have the feature within your EMR or PM system, use a simple spreadsheet to track your PA submissions and associated results. So this next slide actually is going to give you an example of some payer informational summaries. So this actually came from the MGMA workbook. With permission, these are able to be copied. But this is an example of what a payer informational summary might look like. You would list, the payer's information at the top, any contract dates or important enrollment dates, important phone numbers, referral links and how long those are typically good for, services that aren't required for referrals, long-standing referral requirements, services that do require referrals, and any specific notes to that payer that would be helpful for anyone working with that payer. And that information is continued on to this next slide here, just some more additional information. So what we've done in the past, we have Office 365 within our organization and in previous organizations I've worked with. So what worked very well for us was to organize this information into a OneNote where each payer had their own tab. And then we shared that on SharePoint. So every day at the beginning of the day, the staff could hyperlink that SharePoint address with that OneNote file and pull it up. It would be updated every time that there was an update that went out. And all that information would be available at arm's length. So if you have something like that, or if you have a shared drive like an S drive or a network drive, put it out there. Just a good place that everyone can just go out and reach that information so you don't have to reinvent the wheel every time that you need to do something. So this one relates to tracking the PAs and results. So this is just a screenshot of what a simple spreadsheet might look like. I like to use the filter function. I'm big on pivot tables. And we'll go into more detail in a little bit when we get to the reporting and analytics of why something like this is important. But this shows you just a good example. If you apply it in a spreadsheet like this, you're able to filter the information by the employee that touched the authorization. You can filter it by status type. So it gives you can filter it by payer type, by appointment dates, just gives you some good information to be able to create a work list and to provide some level of reporting and analytics. So something that Advantum Health offers, we are a revenue cycle management and consulting firm. So something that we do offer is a web portal to our clients. And this is an example of something that we use. This is proprietary to Advantum, but it's something that we allow access with our clients. So what we do is we put our authorizations into the system. We can import the authorizations, or we can manually schedule those out in our system. And this allows us an easier task list to sort and to do a work list to check PA statuses, to make sure on date of service that we have everything we need to make sure that procedure is going to get paid for and is appropriate. So this is kind of the dashboard view of that. You can see it gives us a total count of like procedures. We can filter by providers and procedure statuses and dates. It's a really good work task list there. And then on the next page, this is the one that everybody really enjoys working from, and especially if you have a lot of procedure-heavy kind of things that require authorization on your schedule. This would show you, for example, a week view of your schedule. And for everyone on your schedule, you can see that it's showing all of those appointments, and they're color-coded. So if it's in green, bright green there, it's good to go, it's approved. But if we had a denied service on that date and it was still on the schedule, we would know to go ahead and take appropriate action, get the patient rescheduled or whatever we would need to do. Okay, and now I'm going to turn this part over to Andrea.
Okay, hello everyone. I'm just going to jump right in and talk about leveraging your resources. So, use of your PM system, your practice management system, and knowing if you are capable of using a 278 file for that prior auth functionality to send and receive from insurance companies. That's important if you have the capability. Develop and adopt EHR clinical templates specific to payers and procedures that facilitate appropriate capture of the guidelines and documentations. And you may use that from the LCDs or tracking and trends that you're finding when, the staff are performing those authorizations. So, good things to use. And then use of payer-supplied technologies. Web portals are always nice, much better than sitting on the telephone. And then for tracking those as well. So play it smart. Submit your requests and supporting documentation appropriately. That's just making sure you have your documentation up front, that you've done a quick review of it and looked at those clinicals that the provider has provided. And you get a feel once you've done them long enough what it is that insurance company is looking for. Never send too much, only what is needed to get the approval, and submit what is required, nothing more. It's just not necessary. Document well, of course, the date and time stamp on all submissions. And reference call numbers are very important, and using in appeals and things, if you've called and were told no authorizations required, and then you get a denial for an authorization on the back end, just important to have that reference number and who you spoke to be able to do those appeals on the back end. Follow up regularly. prevent delays in patient care. So if, I see this often, sometimes they'll say, oh, we won't have an answer for you for 48 to 72 hours. I'm still calling every day because I want to move these along, make sure they're done far enough in advance that everybody feels good about it, that there's no hiccups at the end for issues to happen. And policies are good to have for that, policy and procedure. And then reminders, if you can have that within your system, or, whether it's that spreadsheet where there's a tickler file, or, the portal that we have, is awesome for that color-coded and making sure you know what status it's in. If your authorization gets denied, appeal. Appeals are always important. They can be won. Be organized in your appeal. Be concise and clear with what it is that was discussed on the authorization and why you're appealing. You may, for staff, want to create and develop standard letters for those appeals, just so it's a uniform type thing. Sure, there's going to be verbiage that is somewhat changed depending on the surgery or procedure or visit, but you can create those fairly easy. And then just making sure that you have a library of supporting documentation for appeal types. If you've got something from, say, your orthopedics and AAOE says it's this way, that you have those and that you can include that documentation with those appeals to support your needs. Okay, review and analyze. Review and analyze the information you've tracked. So looking at those trends, what's being denied for specific payers? So this is working in conjunction with your billing company or your, in-house, if billing is done in-house, and getting that feedback. Communication is very important, and making sure those things are done. And then being able to, if you are finding a specific payer, even on the front end, you have repetitious, one provider in your office isn't putting the 6-week consecutive treatment, or they're just missing this or that. Communicate that with a physician, educate them, see if you can update their template so it's prompted that they're completing that documentation. Look at your staffing on those spreadsheets, on those portals. Who's doing well? What's their volumes? What success rate do they have? Is one of your staff members doing better than the other? How can you take that staff member and have them be the trainer? What can you do with that? Pay attention to your successes. It's always nice to give great feedback because it seems like the negatives are always at the forefront of everything. But, out of 1,000 and you get 995% of them correct, I think you're doing pretty good. But it's going to be those 5 that everyone remember. And use the data to make operational changes. What's the workflow? Writing the policies and procedures. Making sure that you're involved with your staff. You know what they're doing, what questions they have, and continuing to educate them on those. Here we're in to communicate and educate, which I've kind of filled in on the previous slides, but it's very important at keeping those providers, and also not just the providers, but their staff, the MAs, or their nurses, that you're educating them, because they don't always understand that administrative side of everything. They just see, oh, I've got to reschedule something if it doesn't get approved, when we're on the timeline of the insurance company, or they go and they change where the surgery is going to happen from this facility to that one. They don't understand that some payers require you to start that initiation all over again, and then your timeline changes again. And if you don't have that notification in a certain time, then it's pushing up to close the gap in the time that they're available to do that procedure. Facilitate periodic meetings with the staff and providers regarding authorizations. What are their pain points? What can you do to communicate to them to make things smoother and try to fill the gap between what insurance is wanting and what you're providing? Make sure that you're updating those payer profiles regularly. Sometimes it changes. and changes frequently. So ensure that those are being updated on that SharePoint and that things are being taken care of in that respect. What will they come up with next? Well, we can only speculate, but as healthcare industry moves to value-based payment models, we should be able to expect a reduction, hopefully, in requirements or change to a different authorization program. So some of those alternative methods include the prior auth sunset programs, where requirements would be removed for services with universally high approval rates. So looking at statistics and saying, you know, what most often do we always approve, or at least 95% of the time, and is it really necessary that we do these? The gold card programs, you know, maybe you have that provider who always documents well, who is very up to date on what qualifies and documents well and make sure he follows the rules, then he may be one of those that, you know, is kind of on an exemption for that. Prior auth waivers, providers using approved and clinically based appropriate use criteria and decision support would be included from authorization programs. Okay, so our conclusion, until major prior authorization reform occurs in the healthcare industry, providers will be required to follow the authorization requirements set forth by the payer. Just remember to know what's required, streamline your processes, leverage your resources, play it smart, review and analyze, and communicate and educate both the provider as well as staff. Okay, that concludes our survey. If you have questions.
Yeah, so Stacy, I think if we can open up the phone lines for some questions, we can do some online here. Also, if you all can think of anything, you know, or you don't want to speak up on this call, you can see on your screen my email and Andrea's email. We'll be more than happy to reach out. If you want a phone call, just send us your contact information. We'd be glad to follow up with you and be able to help or talk about opportunities that Advantum has to, you know, leverage some of these PA successes that we've had within the scope and practice. So we'll go ahead and open the lines up for questions.
Thank you, Brad and Andrea. The lines are open. We have the question box as well. So if you're not able to get through on the line, we do have the question box. And we do have one question that came in through the presentation. So I will read that off. So it's, how do you handle inter-procedure changes and requesting authorizations when the auth for the procedure that you started isn't going to cover what you are actually doing during the procedure?
Yeah, so this one happens a lot, especially among surgeries, especially among, for example, pain management practices. I used to have a doctor in particular that liked to do epidural steroid injections, and then he would change them to transfemoral ESIs mid-procedure. So the big thing is a lot of payers do not allow for retro authorization. So the important key is that that message while the patient is on the table gets to someone who is in charge of the authorization process. So a lot of the payers will allow 24 to 48 hours of a retro for a same-day change. Some do not. Some is same-day only, and some of them do not have it at all. It's kind of really hit or miss. We know it's not a best practice, but also we don't have the controlling hands of the surgeon at the time when that patient is on the table, and sometimes consequently under anesthesia. So my big thing is communication. Let someone in that room, put them in charge of communicating that to the appropriate party to begin that process immediately before even sometimes the patient is out of that surgery. Your other basic level of kind of reprieve there is an appeal process. You know, that's going to have to be supported with a lot of clinical documentation from the provider. So after the procedure, really coaching the provider on, look, we need some detail as to why this was changed. And sometimes it may even get down to a peer-to-peer kind of level for that appeal. Unfortunately, that's just the nature of the process, but those are kind of our best practices as they are. Something that's interesting and that is moving forward slowly but surely is payers are increasingly, with the advent of technology and the internet and all the fun stuff we have the instant gratification of immediate results. And so something that the PA community is really looking into is almost kind of a process by which we get immediate results for requests for authorizations. So as we know now, currently, there's a lot of backwards processes where it has to go in front of a person for clinical decision mechanisms. But, you know, as we move toward things in robotics and their spots within the PA and healthcare arenas, we should see some of that technology leveraging forward. So maybe one day we have the opportunity when we submit those requests for changes, we get an immediate answer. So hopefully that's where we get to, but you know, it's a slow but sure process.
Thank you, Brad. We do have a few more questions that have come in. So the second question I'll ask is, how do you find out if the payer will allow 278 EDI requests?
So that's a really fun thing to deal with. So multifold. I would reach out to my clearinghouse first and foremost to see. The clearinghouse should have a technical IT team that should be able to tell you which payers that they have that availability turned on with. If that particular payer isn't on that listing with your clearinghouse, then you can reach out actually to the payer directly, or having your clearinghouse team reach out to that payer to see if that functionality is able to be enabled, and they'll have to usually work amongst themselves to get that going. That's part one of that. So then you're kind of bound by the limitations of your EMR or PM system. So you would also want to check with that distributor of that system or that manufacturer of that system to see if that's something that they do allow.
Okay. Another question, any advice on ICD-10 codes? So some codes do not qualify. So pelvic pain, pelvic mass, etc.
I think on that, when it comes to ICD-10 codes, trying to get the specificity of what the doctor is thinking. And I don't know if it would be nice to have an example on this. When I think of pelvic pain, and that is very general. So, you know, in regards to that, if you're trying to get an auth maybe for a laparoscopy or something that's exploratory, trying to maybe, I know they don't like rule outs, but you know, maybe getting as specific as to what quadrant, you know, and then, you know, I know there's the ICD-10, but then in conjunction with that, there's the documentation to back it. I mean, unfortunately, sometimes it is exploratory or it's diagnostic where you're trying to figure it out, and that clinical documentation should be there to support and move that through. If someone has a example of that, if you can shoot it to me in an email, I'd be glad to take a look at it and give you some advice on it. That would not be a problem at all.
Okay, thank you, Andrea. Another question we have is, we have a lot of problems with obtaining PCP referrals in a timely fashion for various reasons. We have begun to hold conference calls with PCP office and the payer representative, and it turns into 1-hour calls to get the referral correct, and it is not always successful. Do you have any recommendations on what else can be done to ensure accurate and timely authorizations are obtained?
So this is always interesting. It's kind of like the relationship between operations and revenue cycle. So they're interdependent upon each other. So the best thing that I can advise is to develop good working relationships with PCP offices, whether you have a physician liaison, going out with a clinical staff member or an administrative staff member and developing those relationships. A lot of the payers are actually allowing approvals to be obtained online or request those online. So, you know, that's an intermediary that you can use to leverage. But unfortunately, you know, on some of these HMOs and things where you get locked into a PCP and it requires the referral, you know, just developing and nourishing those relationships with your top providers, that's a big thing. And something that you have to look at too from an operational standpoint is you have to think about, are the number of referrals for the amount of work I'm inputting to obtain the referral from the PCP worth continuing accepting patients from that PCP? So if that PCP is referring you 10 patients a month, but those 10 patients take up the time 30 patients from another provider referring you, to me operationally, that's not worth my time. I would, of course, communicate that in nice terms to that office and try to build that relationship first. But at some point, you have to make the operational decision for yourself.
I think in addition to that, you know, reach out, go, you know, above the person you've been speaking to, ask for a supervisor. But I wouldn't even mind reaching out to the payer and saying, look, this patient, we've been trying to get this referral. We have no cooperation from the PCP. What can you do to help assist with this patient's needs? So I think that's important as well, being that patient advocate.
All right, thank you all. Another question, how do you handle emergency surgical procedures?
Get on the phone immediately, find out what's going on, get that, you know, if the documentation isn't necessarily done from the provider, ask them to wrap it up quickly, but go ahead and get a brief overview of that so that you can give that clinical documentation over the phone and get it initiated. I mean, there are times that it is going to roll over. You're at the mercy of but usually any urgent or emergent, a lot of times doesn't require authorization anyways, fractures, those sorts of things, and those can be appealed if it is get denied.
Okay. That is all the questions that have come through. I will leave the questions page open that you're looking at with Brad and Andrea's information and email. If you had a question that maybe you didn't want to put through the question area, but still wanting to speak with one of them, I'll leave that on the screen. Otherwise, that wraps up our webinar, and I want to thank both Brad and Andrea for a great presentation today.
Thanks, Stacy, for assisting with the introductions and questions and the polls.
And thanks everybody for taking the time today.
All right. Thank you all. Have a good rest of your day.